Thank you for being with us today. Let me introduce each of you on the second panel from my left to right. First is Marcia Crosse, Dr. Marcia Crosse, who's the Healthcare Director for the U.S. Government Accounting Office. Second is Ms. Julie Scofield, who is Executive Director of the National Alliance of State and Territorial AIDS Directors. And third is Donna Elaine Sweet, Dr. Sweet, I should say, who is a professor at the Department of Internal Medicine at the University of Kentucky School of Medicine and board chair of the American Academy of HIV medicine. We try to ask you to limit your remarks to 5 minutes. Of course, you can always submit your statement for the record, and after you're done, we'll take some questions from the members. And I'll start on my left with Dr. Crosse. I hope I'm pronouncing it correctly.
Thank you, Mr. Chairman, members of the subcommittee. I'm pleased to be...
I think the mic is on. Just got to talk a little closer to it.
Pull it over. Is that better? Okay. I'm pleased to be here today to discuss the Ryan White program. As we've heard, this year about $2.2 billion was provided through the program to assist over 500,000, mostly low-income, underinsured or uninsured individuals living with HIV/AIDS. The majority of this funding was distributed through Part A grants to qualifying metropolitan areas and Part B grants to states, the District of Columbia, and territories. Most of this funding is distributed to grantees either as base or supplemental grants. Base grants are distributed by formula, and HRSA uses a grantee's share of living HIV/AIDS cases to determine the amount of the grant. Supplemental grants are generally awarded through a competitive process based on the demonstration of severe need and other criteria. In addition, Minority AIDS Initiative, or MAI grants, as we've heard, are separate supplemental grants intended to address disparities for minorities in access to treatment and health outcomes. 3 other parts of the program provide lower levels of funding to public and private nonprofit organizations for specific purposes and include Part D grants for family-centered comprehensive care to children, youth, women, and their families. When the Ryan White Care Act was last reauthorized in 2006, Congress made a number of changes in the structure and funding requirements of the program with the goals of better targeting funding to areas of need and increasing the proportion of funding going to direct service delivery. For example, Congress changed the process by which HRSA awards MAI grants under Part A and Part B from a formula based solely on demographics to a competitive process to better target funding. The legislation also capped at 10% the amount that Part D grantees could spend on administrative expenses to increase the funding for services. Congress included mandates for GAO to study the changes to the MAI award process and the Part D allowance for administrative expenses. And my testimony today is based on our March 2009 report on the MAI provisions and our December 2008 report on the Part D administrative expense cap. We found that the new competitive process for awarding MAI grants altered funding for Part A and Part B grantees from what they would have received under the old formula-based process. For example, in fiscal year 2007, Phoenix received about 40% less than it would have received under the old formula, while Houston received about 11% more. All Part A grantees that applied for MAI funding received it, with grant amounts in fiscal year 2007 ranging from $50,000 to $9.3 million. All Part B grantees that applied for MAI funding also received it. However, half the Part B grantees decided that the new administrative requirements, including a separate application for MAI funds and increased reporting requirements, were not worth the amount of funds that they expected to receive, and therefore they chose not to apply. For the Part B grantees that submitted applications, fiscal year 2007 MAI funding ranged from $2,500 to about $1.5 million. The change to a competitive MAI grant process did not appear to bring in new service providers or change the approach to reaching minority populations. Grantees told us that they generally funded the same service providers and initiatives to reduce minority health disparities as they had in prior years. With regard to the Part D administrative expense cap, we found that grantees were in compliance with the cap, having charged 10% or less of their grant award for administrative expenses, such as rent and utilities. However, about half of the grantees reported that not all of their Part D administrative expenses were covered by the 10% allowance, and they were forced to use money from their organization's general operating budgets or other sources to cover their actual costs. In addition, grantees such as universities that had negotiated indirect cost rates with the federal government could spend more of their Part D grants on such expenses because they could also charge for indirect costs. These grantees reported spending up to 26% of their Part D grants on indirect costs in addition to the 10% allowed under the cap. While the goal of the cap was to increase services, grantees reported that the cap had not altered either the amount or type of services they provide, and that the cap made it necessary for clinical staff to perform administrative tasks. In summary, our review of the first year's implementation of these provisions did not demonstrate a major increase in services. However, it remains to be seen whether the move to a competitive MAI grant process or the Part D administrative expense cap will meet the goals of better targeting funding to areas of need and increasing the proportion of funding going to direct service delivery moving forward. Mr. Chairman, this completes my prepared remarks. I'd be happy to respond to any questions you or other members of the subcommittee may have.
Thank you. Ms. Scofield?
Good afternoon, Mr. Chairman, members of the committee. I'm Julie Scofield, Executive Director of the National Alliance of State and Territorial AIDS Directors, NASTAD. Thank you for inviting me to speak with you today about the urgent need to extend the Ryan White program, which sunsets on September 30th. NASTAD and the HIV/AIDS community appreciate the long-standing support of the Energy and Commerce Committee and the House of Representatives for the Ryan White program and domestic HIV/AIDS prevention programs that are extremely important to Americans living and at risk for HIV/AIDS. State AIDS directors in all 50 states, the District of Columbia, Puerto Rico, the U.S. Virgin Islands, and 6 U.S. territories represented by NASTAD administer over $1.2 billion in Ryan White Part B base and AIDS drug assistance program funds each year to provide comprehensive care and treatment for individuals living in their jurisdictions. NASTAD, along with AIDS Action, co-chairs the Ryan White Work Group, an affiliated work group of the Federal AIDS Policy Partnership. The Ryan White Work Group is a coalition of national, local, and community-based service providers and HIV/AIDS organizations. The work group developed the community consensus document, which currently has over 300 signatures from 47 states, D.C., and Puerto Rico. There is an exceptional level of cohesiveness in the community around the path for extending the Ryan White program and a growing call for action by the September 30th deadline. I'm submitting the community consensus document for the hearing record. The community is extremely pleased to see that the draft legislation closely follows the community consensus document, and even more pleased with the leadership being demonstrated by the committee to act quickly. NASTAD and the HIV/AIDS community support a 3-year extension of Ryan White that essentially restarts the clock and continues many important provisions for grantees. These include the continuation of protections and penalties for states with maturing names-based HIV reporting systems, hold harmless protection, along with the extension of protection for transitional grant areas and their eligibility. In order to maintain health stability for persons living with HIV/AIDS, it is essential to secure an extension of the Ryan White program as soon as possible, while the larger issues of health reform and the development of a national HIV/AIDS strategy are developed, implemented, and assessed. We also welcome the administration's proposal for a 4-year extension. NASTAD is extremely pleased to see that the discussion draft addresses an issue that has caused undue burden on state grantees. The current law contains a provision that penalizes Part A and B grantees if they have more than 2% of their award unobligated at the end of a grant year by making them ineligible for the supplemental components of their awards and reducing their grant awards in the subsequent years. This provision prevents administrative difficulties for grantees, which must work with subgrantees, deal with budget cuts, hiring freezes, spending caps, as well as manage a variety of funding sources with varying grant periods. The presence of unobligated funds does not signal a lack of need for these funds. Instead, it often reflects the presence of factors that are extremely difficult to manage. NASDAD supports raising the unobligated threshold from 2 to 5% by eliminating the penalty that decreases a state's subsequent year's award by the entire amount of their unobligated balance. States will be able to retain the funds necessary to provide services to their clients. NASDAD believes that the penalty which makes grantees ineligible for supplemental funding should also be eliminated in order to ensure that jurisdictions have all possible funding. Related to this issue is a provision governing the use of rebate dollars accrued through a mix of federal and state A.A.H.I.V.S funds. HRSA has instructed states that they must spend their rebate dollars before the federal grant award. This policy created a problem, particularly when combined with the new stringent rules regarding unobligated balances. Regardless of how rebate income is classified, the Ryan White program requires rebates to be put back into the program. The discussion draft goes far in clarifying this technical issue. We ask that the language be further changed to allow states to spend rebate funds after program funds in all cases, not just if doing so would avoid triggering a penalty. A.A.H.I.V.S are administratively very complex programs, and states need the utmost flexibility to ensure that dollars stretch as far as possible, particularly in these fiscally challenging times. The National Alliance of State and Territorial AIDS Directors thanks the Chairman and the rest of the committee for their thoughtful consideration of NASDAD's and the community's recommendations for extending the Ryan White program. We ask that you continue to prioritize passage of this important legislation and appreciate your ongoing attention to the September 30th deadline. NASDAD and the Ryan White Work Group will continue to do all that we can to support you in these efforts.
Thank you, Ms. Scofield. Dr. Sweet?
Chairman Pallone and distinguished members of the committee, I'm honored to be here today to discuss the reauthorization and extension of the Ryan White program, specifically Part C. I will keep my comments brief. I have submitted a full testimony for the record, and my credentials are in there. But I'm here today as medical director of a Part C Ryan White clinic in Wichita, Kansas, the other KU, who also sees patients in outreach clinics in Garden City, Salina, and Pittsburgh. I'm also a credentialed specialist in HIV/AIDS and the current board chair of the American Academy of HIV Medicine, headquartered here in Washington, D.C. The mission of my Part C program is to provide care and early intervention services to all HIV-positive individuals in the state of Kansas, regardless of their ability to pay. Part C clinics provide care nationally to approximately 250,000 people living with HIV, as well as providing HIV-related counseling and testing. Many have mixed sources of funding, including some or all parts of the Ryan White program. Today, I would like to take you inside a Part C clinic to the front lines of medicine, fighting for the lives of people living with HIV. My Part C clinic provides care and treatment to 1,246 patients. Of these, 40% would have no coverage at all if it were not for the Ryan White Care Act. We provide ongoing comprehensive care to an ever-increasing number of patients. My clinic has an average annual increase of over 100 new patients a year. However, we're still working off the same number of Ryan White dollars we received since 1999. As a result, in the last 10 years, my clinic patient load has doubled, and yet my funding has remained the same. To supplement our insufficient federal dollars, we often do things like annual bake sales, picnics, and other things that the community does in order to support the clinic and its patients. There have been some discussion over the recent years of the concept of the patient-centered medical home. That is what my Ryan White Part C clinic is and has been since 1994. In my clinic, case management, psychological counseling, dental care, pharmacy management, adherence counseling, and when needed, palliative care are all brought together under one roof. This approach has been central to our ability to retain patients in long-term care. The real effect of the Ryan White program, if it were allowed to lapse for even a short amount of time, would be seen on the front lines of the disease in clinics like mine. For my clinic, that would mean losing access to Part C money that pays for care and treatment of over 40% of my patients, Part B money that funds my case managers, and ADAP money that provides drugs for my patients who can't afford them, nearly 80% of the total. On June 1st, I would no longer be able to pay my staff, and they would have to be let go. I've not had any staff turnover in 5 years, and my people are well trained in caring for my HIV patients. They're well qualified and would no doubt have no trouble finding other employment. However, the loss to my clinic would be irreversible. If the Ryan White program were to face a gap in service of even a few months, years of investment in staff and infrastructure would be lost. Without Part C, my patients would have no other place to go for the life-saving services and treatment that we can now offer. Without care, patients' lives would be lost. Over the last 20 years, HIV has become a highly manageable disease with proper care and treatment. In the mid-90s, mortality rates plummeted with the new medicines and treatments that allowed better ways of fighting the virus. Patients are living longer, which brings about a new set of medical challenges. Treating HIV is enormously complex, but it becomes even more so when you're faced now with the medical needs of elderly patients. Fortunately, in my clinic, I now see only 15 to 20 AIDS deaths a year, but that number will increase dramatically if the population loses access to the care they need. The Ryan White program is invaluable to the patients and the providers that it funds, and Congress must not delay in reauthorizing it. Over the past year, numerous HIV and AIDS organizations have come together through the Federal AIDS Policy Partnership, or FAP, to form a consensus on reauthorizing the program. I have participated in those discussions, and I urge the committee to consider the recommendations of the consensus document which you have received. Among those recommendations, however, I would like to highlight a few that are important to me and my clinic. The CARE Act needs to be reauthorized for at least 3 years, and I also like the administration's 4. We need to have assurance of a stable and continuous funding stream in order to care for our patients in the best way possible. Authorization levels included in legislation that was under discussion this year was a 3.7% increase for the majority of the parts, significantly less than the annual increase for community health centers. As someone running a clinic that really has to do its own fundraising to keep its doors open, I would appreciate consideration of language authorizing such sums as necessary in the program, because we have not been getting what is necessary. And thirdly, the provision of core medical services. The 75-25 rule needs to be protected. Additional recommendations are listed, and I will urge the committee to thoughtfully consider them. But in closing, I would like to leave the committee with a few thoughts. Without the Ryan White program, my clinic never would have been created. Without a timely reauthorization, it may cease to exist. And without the clinic, my patients will not receive the care they need. And without that care, the disease they live with every day may unnecessarily and prematurely claim their lives. The Ryan White program works. It is critical to the care and treatment of those affected by this nation's largest epidemic, and I urge the committee to authorize the program with all due haste. Thank you for the opportunity to testify today about Ryan White Part C. This concludes my testimony, but I'd be more than happy to answer questions.
Thank you, Dr. Sweet. We'll now take some questions from the members. I'm going to try to get in 3 questions here in my 5 minutes or so. So first I'll start with Ms. Scofield. In fiscal 09, 25 states and 3 territories were held harmless for base funding or ADAP funds or both. And hold harmless is specifically intended to make sure that states don't face precipitous declines in funding that would destabilize systems and services. Can you tell us more about why the community consensus, including groups from states with both older and newer epidemics, supports the extensions of the hold harmless protections?
Thank you. Well, I think all of us in the community understand that none of the components of Ryan White have received adequate funding in the last several years. I mean, our estimates of need surpass what's been appropriated by about $500 million. So that's part of the issue at hand. In addition, however, when the last reauthorization occurred, there were changes in virtually every aspect of every formula of the program, and it's taking a long time for the dust to settle on the last reauthorization. Money did move around the country, so we're seeing how funds are being reallocated as a result of those formula changes. And in the first year after implementation of the last reauthorization, there were some significant increases to some jurisdictions, and so jurisdictions really were challenged to be able to obligate and use well all the funds that were provided. I think all of us recognize that in this current fiscal environment, what's needed more than anything else is stability in funding. We estimate that state HIV/AIDS programs lost over $150 million in state resources in fiscal year 09. And so really this is not the time for there to be anything but stability in their federal allocations.
Well, thank you. Dr. Sweet, you also talked about the lack of funding. I wanted to ask you about that. Part C provides grants directly to service providers to support outpatient HIV early intervention, and Part C also funds planning grants and capacity development grants. This year, Part C was appropriated $201.9 million, which was only a 1.56% increase over fiscal year 2008. Do you agree that this 1.56 increase for Part C is simply inadequate? And what has been the impact of limited funding been on your clinic and other Part C providers?
Well, thank you. It's certainly been inadequate. We have had level funding, which means rescissions each year over the last 10 years. And we just went through an expansion grant process. The need is so tremendous. They had a lot of good grant applications, but were able to fund very, very few. And Dr. Parham Hobson and Dr. Cleaver, who were back here supporting Dr. Wakefield, I've known for many years, and I know that they are also concerned about the fact that they have many, many people demonstrating need, like my clinics, but the money that was available for expansion grants was simply not enough to give almost anybody what they needed. So, yes, we need more, and I think it's interesting the such sums as necessary was a part of the last reauthorization, but as I have read the bills prior to that, starting in 1990, there were never any monies put in as specified amounts. It always said such sums until this last time. So whatever has been in it is inadequate, and I think, as Julie said, what we need is across-the-board increased funding for all of our programs. What it's done for my clinic is simply made me truly, the 75-25 doesn't mean much to me because I spend 95% on medical care. Between the laboratory studies, the CD4 counts, the viral loads, the genotypes that I need to do quality medical care, I have simply had to cut out all of the other niceties other than case management. Transportation, food services, things like that I now do through individual fundraising, philanthropic things in the community, because there's just not enough money in the grant to do the medical care.
Okay, I appreciate that. Those are good examples. Going back to Ms. Scofield again about the TGAs. According to HRSA, there are 6 TGAs that are in danger of losing their status in fiscal year 11, and the community consensus document recommends extending their status as TGA for the next 3 years, basically the length of the extension that's in this draft. Can you elaborate on this recommendation? Why does the community feel it's important to ensure this continued funding for these areas?
Well, for one thing, TGA eligibility is based on reported AIDS cases because we don't have HIV and AIDS in all of the jurisdictions. And so we know that many TGAs are serving clients with HIV well beyond the number of clients that they have with AIDS. So that's first and foremost. Secondly, I think that we all appreciate that as new jurisdictions may meet the case threshold, they may also become eligible to become TGAs. That just really has not happened. And if you really change and allow these TGAs to lose their funding, there's no guarantee that the states are going to be able to supplant that money. Given the state budget outlook at the moment, if TGAs lose those resources, the states simply are not going to be able to step in and replace those funds. And even though some of that TGA resource might flow into Part B and be available, it would just go out through the regular formula. So again, there would be no guarantee that those TGAs would be left with any of the same resources to provide services.
All right, thank you very much. Dr. Burgess.
Thank you, Mr. Chairman. Dr. Sweet, let me just be sure that I'm understanding correctly. In the last reauthorization of the program, funding for Part C was to increase by 3.7% per year, but the amount of funding that Mr. Pallone just described was a 1.7% increase. Was that a discrepancy between what we authorized and what the appropriators came up with?
I believe that's true, and there were also increased, in terms of an individual clinic like mine, the increase went into new clinics where there are places that's been talked about many times with new small groups of HIV-infected patients that certainly don't meet TGA or EMA criteria, but where they desperately needed funding. So there have been new Ryan White C clinics that have been funded through this time, and the new money went to those. It did not go to increasing the base funds of those of us who've had clinics.
If, in a perfect world, had that 3.7% increase been funded and made available to your clinic under the Part C funds, would that have been a satisfactory amount for you to keep up with what you're doing? And when you describe level funding, is that a consequence of inflation that is eating up the increases that are built into the authorization amounts?
I don't think it would have been sufficient to do all of the things I would like to do for my patients, realizing again, my base grant for Part C in very specific terms right now is $80,000 less than it was 10 years ago because of level funding and rescissions.
Is that in actual dollars or constant dollars?
Actual dollars.
Actual dollars.
And it does not take into account the fact that there's a 2.5% to 3% increase in basic medical costs. My salaries have gone up in terms of my staff, the fringe benefits, the medical equipment and supplies that I buy. So truly, I have faced each year with increased patients a declining amount of money per patient to be able to take care of them. It has made us very efficient, but we are at that point now where there is no more efficiency to be strung out on that string. So we are actually, our base fund is less than it was because of the 1% to 2% rescission that we pay back to the government on any grant.
And explain to me about the rescission, because I'm not quite sure I understand that.
Well, I'm not too sure I understand it. We have GAO here too, but it's amount of money that is sort of taken back, even though you're level funded. There's a little bit of it that stays with the feds in order to administer the program at a federal level. That's a very clinically oriented approach to a rescission.
Okay, well then we'll get to that in just a minute, but let me just follow up on this. And you've heard some discussion up here about we need a number in there or such sums. I mean, here is our problem. We are an authorizing committee. And I always like to point out, first time I went out to visit the NIH, I really understood the difference between an authorizer and an appropriator, because there are no buildings named after authorizers. They're all named after appropriators. So herein is our problem. I mean, you heard Ranking Member Barton talk about this. We want your input on that number. I would like to see us put a number in there and then hold the appropriators' feet to the fire on delivering that number. We're not doing that well with having a number in there now, but how are we going to be able to even know that we're close to the target if we don't describe if we don't give them any sort of target to meet? If they always underfund us by 50%, okay, we'll increase our ask by 50%. There's some logic to follow there, but if we just leave an open-ended discussion at the level of the appropriations, I don't want to leave it up to them to make those decisions, because we all know appropriators are very, very busy, important people. They've got a lot of things to worry about, and the very tiny amounts of money we're talking about in Ryan White may not even cross their radar screen. So help us. All I'm saying is help us with that. When Mr. Pallone writes the bill, I would like to see us put a number in there that is realistic. Now.
Well, I can tell you the coalition has thought a great deal about this, all of the 300-plus organizations that have been discussing this. And what we said for the 2010 coalition request for Part C alone was an increase of $66.4 million over the $268.3 million that was otherwise requested. So we think at least $66 million more. I think the other way that one could get at that number, and I'm sure that the HRSA people can help us, me and you, because we just went through this expansion grant cycle, and I know that they had a tremendous number of very good applications that they could not support. So finding out what those grants would have added up to would be another very in real time look at what community-based clinics like mine are facing and how desperate we are to get some increased base funding.
Yeah, I'd just be careful though about we want to create a wish list of what we'd see in an ideal world or what you need to run your clinic now, today, next year, the year following, and the year following. We do have to be realistic in our assignment of that number. I mean, I think you just described to me what would be a 30 or 40% increase. Did I do the math correctly on that?
Probably, yes. I think it's 30%. What I would be happy with in my clinic is increased laboratory and dental and case management services. Those are things where I'm really, really struggling. I have a chairman who believes in giving my time away. He says I can do that all I want, but when the lab bill comes, you, Dr. Burgess, know what a lab bill is like when you spend the money and then you don't have the money to pay it back. And as an example, Medicaid in my state, I pay $350 for a genotype. If someone is failing therapy, their virus goes up, you need a genotype. That's state of the art. That genotype costs me $350 for my reference lab. Medicaid in my state pays $220.
Well,
So-
Frank's going to fix that in the healthcare, but
Yes,
he told me.
and that's where I have
Because he
some-
loves us, he's going to fix that.
I have some fears about Medicaid covering this patient population, because that would make it even harder. So laboratory services are one of the things that kill us in terms of outreach of our clinics and what we actually do, because it takes us about $160 a quarter to do the basic laboratory management. And those costs go up all the time. So if you ask me if I could get 15% increase, I could probably write my clinic. Do I think I'll get that? No. But I do think the such sums language is just all of the community's attempt to get people to understand that we have been terribly underfunded for a long period of time.
Yeah.
With that said, I can understand why you don't want to give away the budget.
Well, and it's not even a question of that. There are so many other competing constituencies out there, it becomes difficult to advocate for the Ryan White funds when there are other equally compelling cases to be made at the same time. Now, on the issue of the laboratory funding and the genotype, is there a structural problem with the way we're assigning or we're allocating that expense? I mean, that seems like a fundamental problem within the Medicaid system, and I suspect it's not just the Ryan White clinics, the Part C clinics that are being affected. I suspect that is something that occurs much more frequently, and that may be a structural defect that we should correct in whatever we decide to do here in the coming weeks with this bigger bill. So that insight is valuable as well. Dr. Crosse, I apologize, I ran out of time. I'll submit a question in writing. I do want to get some other additional information on the hold harmless issue. I'm worried that we're not giving the money where it's actually needed and where patient care is actually required. But we'll save that for the written response. Thank you, Mr. Chairman.
Thank you. Dr. Christensen.
Thank you, Mr. Chairman. Dr. Crosse, and I'll begin with you. One of the findings that applied to most of the Minority AIDS Initiative Part D grantees is that the 10% cap was difficult to live with, and in order not to sacrifice services, they really stretched everything else. Several had asked for indirect cost rates, and they reported spending 26% of their Part D above the 10%. Doesn't that warrant some kind of a recommendation regarding the cap, and what would you recommend?
Well, the problem that we saw with the Part D grantees was mostly in small organizations. For the Part D grantees that were part of university-based healthcare systems or other kind of larger provider structures, they had sufficient other kind of general funding available to cover some of these things like rent and utilities.
If I could just say that the Minority AIDS Initiative is really to try to get to those small organizations and build a capacity in those small organizations.
Well, the administrative expense cap was just for the Part D grantees. And so that didn't apply to the Part A and Part B grantees, which was really the focus of most of the work we did on minority AIDS initiatives. The Minority AIDS Initiative work that we did really focused on the grants flowing to the Part A and Part B grantees. There, one of the issues was that just the funding for the states was quite low. It was about $7 million in total that went out to the Part B grantees, and so when states were generally receiving something in the order of tens of thousands of dollars, that wasn't enough for them to be able to establish new clinics, create new infrastructure, to be able to move to care more directly into the minority communities, as I know you had expressed as a goal of this program. The Part A grantees generally were receiving several $100,000. Again, when they had existing infrastructure that they wanted to continue to provide funds to, there wasn't enough funding, there wasn't enough increase in funding, even with the switch to a competitive process, where new clinics could be established in minority neighborhoods to improve some of the problems about access, transportation difficulties, clinics focused particularly on minority populations, that had been one of the concerns driving this program. And so what we found was that, yes, the dollars were going to provide services to minority patients, but it wasn't creating new service providers. It wasn't creating new streams of service or new kinds of structures to bring these services to the communities of color.
Thank you. Ms. Scofield, thank you for the answers that you've already given. They were very helpful. But I'm unclear on where NASDAD stands on the severity of need index. Does NASDAD believe that these should be components of the funding allocation process, perhaps not next year, but at some point?
We believe it absolutely is not ready for prime time. We've not really had the chance to look at all the indicators that have gone into it. We're pretty convinced that not all of them are able to be collected in a consistent manner across all jurisdictions. And frankly, we think it has a lot more work to be done before it would be ready to be used in any formula for the allocation of resources.
It should be a part of the process that we should work towards?
From my perspective, the best indication or the best thing to be using in a formula is disease burden as it relates to living HIV and AIDS cases. I think that actually is the best measure of making sure that the resources go where the epidemic actually is.
Okay. Dr. Sweet, thank you also for your testimony. I think it was representative of many Part C and other grantees under Ryan White across the country with the tough times making ends meet. So thank you for your commitment. Other than the money, and you may have mentioned this in response to Dr. Burgess, but my question was, other than money, are there changes that in the bill that you'd like to see that are not in our proposed legislation, and where do you stand on the medical and nutrition and medical transportation proposals?
Well, certainly, I very much appreciate the bill draft that you wrote. I think it does reflect what the community has asked, and these meetings and phone calls have been, when you put 300 voices on a phone call, it becomes difficult, and I think the fact that there has been a community consensus is something we should all be proud of, because we have worked to make it a consensus. The last question is more difficult because that last question is all about the money. Certainly, in the best of worlds, I would love to have more nutrition money, more transportation money. Those are the two things that my patients need that I would love to give more of. But when I have to, in this day and age, I can get someone to live 20, 30, 40 years if they get the right medicines, the right medical treatment, and I do it right. So that medical care has to be preeminent in what I do. And consequently, the other support services that I would like to do, I have to short shrift in order to do the medical care. So that's all about the money. If I had enough money, then the 75-25 wouldn't be an issue, and I would love to be able to go back to the days when I was able to offer nutritional supplementations and a lot more transportation than I can now. So, and back to the amount of money, I just thought, Dr. Burgess, I applied for a 20% increase with my expansion grant, and that would have made me much wholer and much more able to give more comprehensive services. So, about 20% would be what my clinic needs in answer to your question over what I get now.
Thank you, and thank all of you. Really, this was very helpful in terms of, our moving forward with this bill. I would, Dr. Burgess, there may have been others mentioned that they may submit additional questions for the record, and we ask that members submit those to the committee clerk within 10 days or so, and you'd be notified, when those come through. But again, I want to thank you all. I know there weren't a lot of members here for the last panel, but the questions were good and the answers were very helpful. So thank you, and without objection, this meeting of the subcommittee is adjourned.